Hello, everyone. I'm excited to be here. I was going to say good late morning, but now I think I'm probably what is between you and lunch, and I promise that I will make this worth your time. So metabolic psychiatry in this approach is really an approach that focuses on the connection between our metabolism and mental health. Everyone here knows that mental health has a very heavy toll on individuals and a very heavy toll on society. I think all of us would probably not be in this room if that wasn't the case. Patients with mental health conditions, especially serious mental illness, significantly have a reduced life expectancy of about 10 to 20 years, earlier than the general population. So this is a really big deal. So what are the hints that metabolism play a role in mental illness itself? Now, we have Dr. Chris Palmer here in the audience, who's written a wonderful book on brain energy, metabolism, and deficits. If you are interested in this topic, please read his book. We have roots of our mental illness that lie in metabolism and how our bodies process and use energy. In many parts of the world, we're seeing a rise in metabolic disorders as well as mental health conditions. So it's not just a coincidence. It's also interesting to note that over a century, or about a century ago, we noticed that there were biomarkers in psychiatry, and those were glutathione, a lowered level of glutathione, and increased lactate. And these are measures of bioenergetic dysfunction. So a lot of people ask me, how did I get into this area of mental health and metabolism? And what I'd like to share with you is that I had an interest in metabolism from the outset, from my medical training. And I was at Duke Medical Center, and I had some experiences in obesity medicine and training. And I saw patients that were getting off their diabetes medications, getting off their blood pressure medications, which was pretty much the opposite of everything else I was seeing in medical school. And I also saw, very interestingly, that psychiatric symptoms were improving in some of these patients. And there was one particular patient that I met who had treatment-resistant schizophrenia most of her life, and she was on a ketogenic metabolic therapy that was helping her, and it improved her psychiatric symptoms. So I saw that she also was being treated for obesity and this at the same time. So that got me very interested in this intersection, whether it came to binge eating or food addiction or a psychiatric illness. These were things that I was noticing that weren't necessarily being addressed in the clinic because it was a focus on obesity and weight loss. And I started to feel like medicine was too siloed. We had field, primary care, we have psychiatry, we have neurology, but it's all connected, right? Our bodies and our minds are connected. So I saw this gap, and I felt a need to merge it and kind of break that silo. One of the reasons why I felt metabolic psychiatry made sense is that we're merging this connection, and it also gives a unifying term for clinicians and scientists in addressing how metabolic dysfunction can affect mental health. One thing I did want to mention is that with medications for psychiatric illnesses, they are life-saving, so I'm not advocating that we're just focusing on metabolism or diets and removing medications completely. That would be dangerous and not a good idea. We also know that medications can preserve brain tissue from some studies. We also know it can exacerbate metabolic side effects, so we need to take into consideration all of these pieces in treating an individual. So the way we define metabolic psychiatry is it is a metabolism, it's a study of metabolism-based interventions in psychiatric disease, in treating psychiatric disease. So whether that is nutritional, or pharmacological that applies. So it's more of an umbrella term to describe how these interventions are affecting mental health. You may have heard of nutritional psychiatry, which has been around for years, and it's taught us a lot of what we know about diets and micronutrients, macronutrients, eating patterns like Mediterranean diet, and how that affects mental health. Metabolic psychiatry takes it one step further to look at the pathways of metabolism and the disruption in these pathways and how that leads to symptoms of psychiatric disease. So here at Stanford in 2015, we established a metabolic psychiatry clinical and research program. And we are also employing, looking at treating insulin resistance and seeing how low carbohydrate or ketogenic therapies can affect mental health. So what are the relationships between, what are we seeing relationship-wise between the metabolic dysfunction and the psychiatric disease itself? Recent research has revealed that there is this very powerful connection between metabolic dysfunction and psychiatric diseases like bipolar illness, like schizophrenia, and major depressive disorder. Patients with psychiatric conditions are at significantly higher risk for type 2 diabetes or other cardiometabolic diseases. We are seeing that even before the diagnosis, that we are seeing problems in insulin and glucose handling in the brain. What are some of the comorbidities that might stand out here with this population? I want to mention that the prevalence of obesity among individuals with schizophrenia is almost double that of the general population. Metabolic syndrome, which is really a constellation of symptoms and signs that really point to insulin resistance, is about 37% in bipolar disorder. How do we know that there's a biological basis for this hypothesis? I would say that there's decades of research that's unraveling the biochemical pathways and looking at this relationship. Things that we're seeing in bipolar disorder would be mitochondrial dysfunction, we're seeing insulin resistance, as I mentioned, we're seeing brain energy metabolism deficits. There are genetic studies that are also showing mitochondrial DNA deficits or alterations that can contribute to bipolar illness itself. And again, the metabolic dysregulation is something that we're seeing beforehand, before the onset of psychiatric disease. Some of the mechanisms with schizophrenia that we're seeing is that there's altered glucose utilization in the brain. There's something called cerebral glucose hypometabolism, which is really areas of the brain that are not efficiently using glucose as well. And that's something we also see in neurodegenerative conditions as well. We see gene expression changes in glycolysis, and the mitochondrial function changes. What are we seeing in depression? We're seeing that insulin resistance and inflammatory markers play a pretty critical role in depression. So I'll give an example of a study a colleague of ours did in our department looking at insulin resistance, and 1 in 3 people in this room and in the United States have insulin resistance. And you can't tell that just by looking at someone. Someone who has normal BMI can have insulin resistance. If you have insulin resistance and even no previous psychiatric history, your chances of developing major depressive disorder is double. I believe that metabolic psychiatry offers a very new, promising approach to new avenues of treatment. And I would say that it is based on a lot of decades of research in how ketogenic therapies in particular have shown to be effective in epilepsy. So we have a diet, a ketogenic therapy, that is really a metabolic therapy. It's high in fat, it's moderate in protein, and it's low in carbohydrates. it puts the body into a physiological state of a therapeutic ketosis. You're breaking down fat, you have blood ketones, you measure those ketone levels between a certain range. And I will talk more about that as I talk about our pilot study. People want to know if this is helpful, if it's working. What I'd like to share with you today is a little bit of our pilot data here from Stanford. There's also another pilot that was recently published from Ian Campbell in the UK and his group. These are the two pilots that we have. There are a lot of other trials underway, nine trials. Some of them are randomized controlled trials, and they're generously funded by philanthropy, including the Baszucki group here in the audience. So we're very excited about the future of this research. And we have some preliminary data that suggests that being in a sustained state of ketosis might stabilize mood in bipolar illness and alleviate symptoms of psychosis in schizophrenia itself. So the goal of the study we did here at Stanford is it's really a proof of concept study. It's a one-arm study, cohort, outpatient, and we're really assessing the feasibility, the safety, and the tolerability of this intervention. That's really going to inform the design of future studies. What we did is we separated the data into those that were adherent versus semi-adherent, and then analyzed the data. We also analyzed the data as a full cohort. Now, what that means is that when you're measuring therapeutic ketosis, which is a term that was coined by Dr. Stephen Phinney in the world of obesity and diabetes, and that is a range of 0.5 to 5. So what we did with these patients, they either had a diagnosis of schizophrenia or bipolar, they did a ketogenic diet intervention for 4 months, and we monitored them and followed many outcomes. If they had weekly ketone readings, if they generally were in the realm of 80% or more in this therapeutic range, they were considered adherent. If they were in the range of between 60 and 80, they were considered semi-adherent. If they were 50% or below, they were considered non-compliant. So this graph depicts the adherent in red, the red group, and semi-adherent in the gray. And it is by percent change for metabolic biomarkers here. So generally, we saw greater changes in the adherent group versus the semi-adherent. There was a 30% drop in triglycerides. There was a 35% reduction in the insulin resistance measure HOMA-IR, a 15% improvement in omega-3 index, a 17% reduction in inflammatory marker HSCRP. And at the beginning of the study, we looked at who met criteria for metabolic syndrome. We weren't necessarily recruiting for those with metabolic syndrome, but anyone that had a metabolic abnormality, we included in the study, as long as they had one metabolic abnormality and a diagnosis, DSM-5 diagnosis, they could partake in the study. So 28% of the cohort met criteria for metabolic syndrome, and that was at the start. By study end, in 4 months, we measured them again, and none of them met criteria for metabolic syndrome. And I know these are numbers. It's a small pilot study, but this was so clinically meaningful and so wonderful for our patients. It was encouraging that we also saw improvements in the semi-adherent group versus the adherent group also. And that means that there's still some benefit from engaging in this change. So what is this table showing? This is the average number of medications that patients were on when they entered the study. That is 4. That includes psychiatric meds or other. Majority of the medications, psychiatric medications, are neuroleptics, which are known as antipsychotics. Mood stabilizer, antidepressant were the majority. The average participant here in the trial had at least one suicide attempt in previous hospitalization. So this wasn't a mildly ill population, many treatment-resistant folks in this population. I didn't include anyone in this study that had a change in medication a 1 month prior to entering. And I allowed changes in medications as is with their psychiatrist, didn't influence that, and just looked at the observations of what happened. So almost half had no changes in their medications by end of study, roughly, but 30% had a decrease. This slide and the next focuses now on people at baseline that had elevated symptomology. So we were interested in looking at recovery and response rates. So anyone that had elevated symptomology from the beginning, we took that separately from the rest of the cohort. We categorized everyone based on adherence and semi-adherence again, but also looked at what category they belonged to, whether they were in the recovered state, whether they were recovering, whether they were in the depression category, hypomania, or symptomatic. So basically, in this graph, you can see that there are everyone that started with elevated symptomology in the adherent cohort, 50% went into the recovering state. And then the other 50% went into recovered state by the end. If you look at the semi-adherent cohort, even though they're small numbers, it's just interesting to see that 60% went into recovering and 40% recovered. Now, CGI is a standard clinical global index of severity that we use in measuring both with schizophrenia and with bipolar illness. So anything above a CGI of 2 is considered symptomatic, and a change to 2 or less is considered recovery or remission. So what we did is we looked at that, and we wanted to see if there was at least a 1 point change, a 1 point reduction in CGI, which is clinically meaningful. And a lot of the studies in our field look at 1 point CGI reduction as clinically meaningful. If we look at that, over 79% had that clinically meaningful change with 1 point of the CGI. If we separate that, again, in adherent versus semi-adherent, we're seeing that with the adherent category, 91% showing improvement with 1 CGI reduction, and the semi-adherent group showing 50% improvement with 1 CGI. So that's huge. What are the big takeaways from the metabolic measurements? Again, 30% drop in triglycerides, 35% reduction in HOMA-IR, the insulin resistance measure, 15% improvement in omega-3 index. Again, I mentioned the metabolic syndrome. After 4 months, they no longer met criteria. Psychiatric markers, we saw a 30% decrease in medication use. We saw 46% showed a significant CMM recovery rate. Again, 79% showed a reduction of 1 point on CGI. Again, the numbers are small here, so I don't want to draw big conclusions, but an average of 50% of our patients recovered, which is really encouraging. So what is the future? Well, we're planning to publish the full data set early 2024. We did publish 2 papers over the last year showing the preliminary data from this trial. One of them is Journal of Affective Disorders. Further research is needed. We do need randomized controlled trials to explore this positive signal from the pilot, and we are in the process of trying to plan that. I'd like to share some qualitative feedback that we received with you all, and these quotes are both from 2 participants from this pilot study. Since being on the diet, I haven't noticed any significant anxiety levels or attacks, and I've been able to work through basically everything I've come across. It can honestly save a lot of lives. It saved mine. I would not be here today if it wasn't for keto. So I want to thank and acknowledge my team and collaborators here at Stanford and externally, as well as others from globally. that have been part of giving advice and encouragement, and of course, the patients in this trial. I would like to also thank the funders for making possible this work, including the Baszucki Group, the BC Treatment Foundation, and also the Stanford Medicine Metabolic Psychiatry Clinic, and the support of my chair, Dr. Laura Roberts. It's been inspiring, honestly, to see how quickly metabolic psychiatry has grown. It's much larger than any one person, and it brings new hope to patients. I wanted to share just a couple of the trials that are underway right now in the ketogenic diet and mental health, and I'm happy to share this list with anyone who's interested. We have Zoltan and Carlo at James Cook University, Harry and Ian Campbell I mentioned in the UK, Dominic D'Estago from University of South Florida, Jeff Volek, who's looking at ketogenic diet and depression at Ohio State, and Judy Ford at UCSF, who's also looking at schizophrenia and bipolar, and Lily Mujika as well, who's also doing a study in bipolar. In closing, let's remember that mental health is not solely about the mind. It's intricately connected to our body's metabolism. By embracing the principles of metabolic psychiatry, we're taking a significant step towards a brighter, healthier future for those affected by psychiatric illness. I'm happy to answer any questions anyone has. Now in the future, feel free to reach out if you have any questions. Thank you for your time and attention.
Shebani, wonderful talk. It's great to see you again. Thanks for this amazing work you're doing. So, very impressive results in this initial preliminary phase. Congratulations. Did you track any potential side effects of the ketogenic diet on the patients that could be troublesome, or did you also track any difficulties with acceptability of the ketogenic diet to the patients over a long period of time? I have several friends who live with schizophrenia who don't like the medications they're taking for very good reasons, and might benefit from something like this if it is effective, but we'd love to tell them more about it. So just let's hear more about this. Thank you.
Yeah, thank you, Brandon, for that question. Great question. It's we did track side effects at every single visit, and they actually had 10 medical visits total over the course of 4 months. Within the first 3 weeks, any side effects from a ketogenic diet were pretty much non-existent. And there are very common side effects that do occur when someone does start embarking on a ketogenic therapy, and usually it is in the first couple of weeks, especially during the adaptation period, where they will experience those symptoms. So great question. I didn't have time to go through all of my research slides, but there's one person that was non-compliant. And this also, keep in mind, this happened during COVID. There were also challenges regarding that. But overall, people were pretty compliant in this trial. Mm-hmm.
Hi, Shebani. Thank you for your talk. I'm Brett Scher, Director of Metabolic Mind. We're a nonprofit initiative of Baszucki Group where we focus on this connection of metabolic health and mental health. I want to focus on one statement you made about more research being necessary. And as a researcher, makes total sense, right? You want the gold standard of research care. But I want to ask you if you see this differently. If you're talking about a medication, nobody has to take a medication. So if you're going to have a medication you're going to take, it needs the gold standard of research. But here we're talking about nutrition. Everybody's got to eat. So do we need the same standard? Or do we use Ben as an example, who, by the way, has an interview on Metabolic Mind's YouTube channel, which I got to plug. It was a great, thank you very much for participating in that. But so that someone like Ben who's looking for a treatment now, who doesn't want to wait 5 years for the randomized controlled trial, do you see this differently since it's a food intervention? In other words, why not try it?
Yeah, great question. We use a lot of things off-label. I don't see why a nutritional intervention, can't be used if there's no harm, right? And so I think there's two different questions here. One is this a adjunctive treatment that's improving psychiatric disease, right? And doing a randomized controlled trial can help with that question. If you're treating metabolic syndrome, insulin resistance, we have so much data for that. And that can be used. I think other psychiatrists, I think, will feel more comfortable with that approach. Now, I'm biased. I think it's helpful for both. So I use it clinically. I practice it. But what I'm thinking about is a little bit more around our field and what would be needed for adoption. So I do think that a randomized controlled trial or further research to actually make a more significant positive change over time that's long-lasting, I think that would be helpful. And of course, we have a lot of data for neurological conditions. We don't have it in mental health, but it's the same organ. So that's really interesting. We do have information on what is happening in the brain, and we should apply it.
Okay,
that's my answer.
Yeah, you've had your hand up for a while, and then
Yeah.
we'll go for lunch here. Almost there.
Thank you. Hi, I was curious to know if there was any differences in impact with men versus women, just because also with women, I've seen different things in terms of like some of the negative side effects on how a ketogenic diet can impact women. Mm-hmm. And so I'm just curious to see in terms of, mental health, the impact of it. Was there any difference in men versus women?
Yeah.
Also, like based on their cycle, like I think it can be dependent on, those kinds of things. So.
Yeah, it's an interesting question. It came up actually at a talk I did earlier this year. And the pilot data, it's too small of a population to look at sex differences. I think over time we can compile data from all the trials and look at sex differences. I'll tell you clinically from my experience that I do think that there's higher rates of eating disorders in females. Men have eating disorders too, but there are higher rates in females. And I do think that the approach to take is slightly different with folks with eating disorders, and being careful about their obsessions or thoughts about food, rule-based type of thinking or rigidity. I think that can be problematic. And we just want to make sure that they're also not going too low on weight too. So I think that's also a concern. But overall, there was actually a study we published on food addiction and symptoms of food addiction, binge eating, which actually improved on this approach. And so I think there's a lot of room for understanding that. And there's a clinical trial another researcher is doing on looking at anorexia specifically with a ketogenic diet. So that'd be really interesting to see as well.
Great, thank you so much. All right, big round of applause. So I'll give thank you.